to whom they don't know me, I'm a vascular surgeon. I'm working in my clinic, in private practice, also in the hospital. I am in charge of the as a medical officer in VB Devices. The VB Devices is the company that developed the device VARIXIO and other two devices. We are talking about that. We are talking about truncal veins and how to manage these veins using foam sclerotherapy, in this case, using the device VARIXIO. But of course, other sources to prepare the foam can be useful for these indications. The first slide I want to point out is in 2022, and the last guidelines, the European guidelines, foam sclerotherapy has been considered as a technique of choice in cases of anatomical configurations that made the endovenous cannulation complicated. But not only in those cases. I was very happy when I read the other new recommendations for using foam sclerotherapy for Saphenous trunks in less than 6 millimeters. This is something that we can discuss. Or in case of pelvic escape points, in the anterior saphenous veins, recurrent varicose veins, and other indications. And I have to say that regarding the evidence interpretation, there is something to discuss because it depends on the perspective of the physician. Here you can see a full glass or an empty glass. And this is related to this more information that I want to share with you. In this review, you can see the success rate of ultra-guided foam sclerotherapy was very variable, from 84% of occlusion rate to 43% occlusion rates. This is a good result, is a bad result. But if you read the title of this paper, the title was assuming that ultra-guided foam sclerotherapy is safe and effective. In this other paper, this is a randomized controlled trial. I found very interesting conclusion, but in this randomized controlled trial, they compare the effectiveness of the laser or the ultra-guided foam sclerotherapy for small saphenous vein after 3 years of follow-up. And what was interesting is good results or better results for laser in occlusion rates, but technical success was better, but not was a clinical difference between the two strategies. So I would conclude that despite the occlusion rate, no differences have been found regarding the clinical recurrence or the quality of life. And that's the reason because we are discussing here and trying to convince you that the use of foam can be useful for big veins. These other papers can show you can see here the occlusion rates from 56% in this Hamilton's trial, but up to 90% in the Dick paper, Talutis paper, and recently in the Marianis paper published in 2025, and 85.5% of clinical success after 5 years of follow-up. So then we are talking about an office-based procedure. This is something that you can do in your office. Mostly you only need a duplex, stretchers, tools, light source, a table, complementary table, and a system or not. This is the type of material that I am using. And if you have a clinic for sclerotherapy, you need to have a different type of materials. You need some short catheters, long catheters, different types of needles, because you have to adapt to every patient the access with using different needles, of course, to help to the stocking. This is the VARIXIO device that I have prepared with the capsules. Different type of cotton balls to do or to prepare the extractive compression in different sizes of varicose veins, creams to apply after the procedure, saline. I will show you how I'm treating my patients. I'm using a lot of saline to flush, to wash the vein, to empty the vein, clocks to control the time for to pull the resting patient, different concentrations of sclerosing agents. In some cases, I'm using glycerin for making the foam more stable and more homogeneous. So anyway, a lot of different details that I recommend you that if you are setting up a clinic for sclerotherapy, you need all this type of material. Or to make easier to control the patients, to make the photos of your patients. This is a very easy and cheap installation as a ladder with a curtain that you can put up and down, and then you can do your pictures always at the same way. And to manage your photos, I would recommend you, if you're using iPhone or iPad, I would recommend you just the very simple tip is just to put a tag with the number of the patient, and then automatically you can look and search your photos just introducing the number of the patient. This is very, very easy. You don't need to invest money in having a new and a complex program to manage your photos. So then, of course, other complementary equipment, emergency material that hopefully you don't need. Then to prepare the foam, I am using this device, the VARIXIO device. It's composed by a fixed equipment, the VARIXIO ProMag, and two types of capsules. The capsules of O2 CO2, the low nitrogen capsules, and the capsules with air. Both are prepared with sterilized gases, but low nitrogen is thought in cases of patients with migraines, patients with are probably affected by patent foraminal, or in patients with big veins. We are talking now about truncal veins. And in this type of patients, I would recommend the use of low nitrogen because of the volume of foam that you finally inject. Why I'm defending the use of dry foams, not only for spider veins. I know this is very controversial, but I'm using dry foam for small veins, but especially in big veins. Because in big veins, you need to empty the vein of blood. And to do that, it's easier to do it with a more consistent, more stable, and more dry foam. We consider a dry foam when the ratio is 1:5 or more. 1:6 in this case, when you use VARIXIO foam, 1% air, the ratio is 1:6. 1% low nitrogen is 1:7 with these diameters and characteristics, and also for the 3%. Let's go to the details. So about syringes, don't use less than 5 ml syringe. It doesn't make sense to use small syringes if you are treating big veins and you assume that you're going to inject at least at medium of 10 mL of foam. The use of filters, this is very is interesting because if you are using low silicon or non-silicon syringes, these filters gives more homogeneity and soften the injection. And we have the details about this product and we can share with you other details that we can comment during the videos. And don't forget about patients that are afraid about needles. This is a very simple way to give more relax to your patients. This is a squeeze toys. We have 3 videos. The first video is related to the treatment of GSV or SSV for one-access procedure. The advantage of the one-access is because it's less volume required, it's faster, and gives the opportunity to make the sequential treatment of tributaries. That gives less inflammation to the patient. The disadvantage is because your patient would need more sessions. And secondly, when you are treating only from one axis in the great saphenous vein, the occlusion rate is slightly worse than if you are using more than one axis. For a small saphenous vein, mostly is enough. One axis is a minimally invasive approach for SSV. But what is important in SSV is the control of the volume, the total volume of the treatment, because you are treating and you are injecting a good foam very close to the deep venous system. So then in this first video, you will see how I treat, in this case, the a great saphenous vein, a small saphenous vein. The patient is prone, is face down, and my approach always with the probe is a longitudinal vision. I'm using 2% polydocanol with a butterfly 25G. And you can see that although the foam is dry, you see that there is an image that is not spasm, the really spasm made, but sometimes when you see and when you look with the duplex, you need to make some maneuvers for pressure to facilitate the spasm. This is the control after 3 weeks with the total occlusion. In case of a great saphenous vein, in this case, only with one axis, I do an axis in the middle thigh. The patient the positioning is to left side, and I put a mark in the more or less in the knee, trying to make less outflow from the distal part of the vein. Here you see the detail how I put the short catheter. I am using this instead using the direct puncture because what I would like to do is to control in every time how the foam is going, if the spasm is effective or not. You will see now the spasm, the test of spasm to check how volume, the total volume of foam that could be need to be injected. Here you see this is the vacuum effect, and there is blood in there, so it's a negative spasm test. That means that you need to inject more foam until the spasm is withdrawing white foam. Once you have this spasm, it is not necessary to inject more foam. Otherwise, you are injecting the foam to the DVT, to the deep venous system.
Vete a la pantalla del record.
Okay, after 3 weeks, this is the occlusion. There is some areas that there is a partial occlusion, and then in that case, I would retreat not only this area, but the down part of the leg that it has been not treated, because remind that this is only one axis treatment.
Okay, pass.
Next. This is another case of two axis treatment. Sorry. No. Okay.
I'm sorry, Enric. We have a question in the
yes,
chat.
Okay.
Yeah,
Yes,
so
go
Dr.
ahead.
Bertoni is asking if the patient is in Trendelenburg position when you inject.
Yes, I am injecting. Okay, it depends. In the case of a Trendelenburg, you will see the next cases. In Trendelenburg position, I started the treatment from the thigh part of the leg. But you will see that now I am changing my practice and I am doing like the English method. The patient in Trendelenburg, once I flush the vein and empty the vein, I start to inject the foam from the distal part of the leg. I will show you. And then this is easy because you obtain a good effect in the distal part, in the median part of the leg, and also in the proximal part. Because when you go to the thigh, you will see some foam coming from the down part, and you would have a squeeze vein that is easy to have a good spasm. We will comment afterwards. This is in case of multiple 2 or 3 axis procedure. The advantage for GSV is because it's the higher occlusion rates, less sequential treatment of tributaries for the next sessions. But the main disadvantage is first, more volume required, and second, more inflammation. You have to explain the patient that sometimes the distal part of the vein, tributaries, can be more inflamed because of the overdose of the foam. We will comment afterwards that what is ideal is to change the concentration of the foam. If you are treating in 2 or 3 axes, I would recommend to use 1% or less polydocanol concentration below the knee, and in the thigh, where the great saphenous vein is surrounded by fat, I am using 2% or 1%. This is my experience in order to avoid the inflammation. For SSV, 2 or 3 axes is not very common, but if you have to treat or if you want to treat tributaries at the same time, you need to control the total volume. But you can do it. But for SSV, I mostly am using 1 axis only. This is a case, a video that shows how would be a 2-axis treatment. And this is a Chinese cook that she didn't want to go up of work. She wanted to go to work the same day of the treatment. And here you see how I put a butterfly in the tributary, the main tributary below the knee. And then I put a short catheter in the longitudinal view as I presented before. This is a 18G short catheter. And then I elevated the leg. And you see that next to the puncture, I keep there syringes with saline that help me to flush and to make it easier and more convenient, the procedure. Once you have the patient in position, then after flushing the vein, in this case, I started to use or to inject the foam from the thigh. And then with the duplex, you control how the foam is navigating. Here, this is a test for the volume, the spasm test. And at the end, I put excited compression and class 2 stocking. This is a 2-axis procedure. And now,
Enric, sorry,
yes.
just to pause for a second here, because we have another question. So
Okay.
the question in the chat is, how do you determine the volume of foam that needs to be injected into the vein trunk? Is there a calculation for the length and diameter of the vein?
Yes, no, but honestly, what I would say is theoretically, if you want to calculate, you can calculate by the formula PR cuadrado, but this is something that could change. So theoretically, to know the volume, you have to multiplicate P per the radium and per the length of the vein. But practically, I would recommend to use the spasm test. The spasm test consists in once you have injected the foam and you see the foam is in the vein with a correct spasm, with a spasm of the vein, then you withdraw with your syringe to test if come blood or come white foam. If when you withdraw you have a blood, then it means that you need to inject a bit more. If you withdraw white foam, then is enough. I will show you now another test. ¿Podemos ver la próxima? No sé por qué.
Solo aquí. Ya lo pongo.
Ponlo.
Ya está.
And Enric, we have another question from the participants. So
Yes.
Jaral is asking, may I ask about the concentration used in GSF? How long you're going to keep your patients on compression?
Yes. I put the assistant. Okay, stop. So normally what I am using is for bulking veins or for big veins, dilated veins, I am using eccentric compression. At least during 2 to 3 days, I am putting gauzes or something that they compress this, and I apply elastic bandaging or inelastic bandaging, and then stocking over this. The stocking during the first 2 to 3 days, I keep the stocking without taking it out. After 2 to 3 days, they can take a shower, put out the excited compression, and wear the stocking during the day until the next session. So every day they need to wear stocking during the day for 3 weeks. That what is the normal time that I have I give to my patients for having the follow-up. It is okay.
Yes.
So let's go to this is another case. This is the 3 axes. In this case, I put 3 different axes. Mostly in the thigh, I put a short catheter in the middle thigh, and in the rest of the varicose veins, I try to use butterflies because I feel are more convenient. You see, next to the axis, I put different syringes with saline that are very, very useful to use it for flushing the vein and to test the spasm test. In this case, this is a long, tall patient. I would estimate more than 15 mL of foam would be necessary to fill from the distal part to the upper part. And in this case, I recommend and I use a low nitrogen. always using the duplex as the guide of if the foam is doing the effect that I'm looking for. Here you see this is a negative spasm test. That means that you need more foam, more time, more stability injection, and keep the foam in place. Now you would see how I do the spasm test, positive spasm test. Now you see, this is the vacuum, okay? And the vacuum is white foam. It means that is enough. After this, I take out the different butterflies. I apply the eccentric compression. You will see. This procedure is, I did it, this procedure last week. It was a 22 minutes procedure from the beginning to the end of the procedure when I put it the stocking. This is a type of compression packaging that I prepare just with gauzes. I keep this in this situation at least, as I commented before, at least 3 days. People asking about the shower, and then I recommend that they take out the stocking, but they cover the entire leg with plastic, with kitchen plastic, and then they can take the shower without having to take out this.
Enric, I think now
Yes.
is a good time to have some more questions. So first of all, there's a question about the brands of syringes. We will come later to that point, I guess. But we also have a question regarding, there's a point that says, there is a claim that the smaller the needle diameter, the greater the likelihood of foam destruction. Wouldn't it be better to use a 24G or smaller cannula instead of a butterfly needle?
Honestly, thank you for your question. But honestly, I have to say that it's very common that the structure of the foam, with you are using liquid foam, liquid or wet foams. The more wet is the foam, the less stable. If you are using 1-5 or 1-6 with a very small bubble size, you can also use a 30G needle. In the past webinar, I showed some videos that demonstrated that if you are using the VARIXIO machine that is preparing the foam with very small size and with ratio 1-6, 1-7, you can obtain a very good quality foam also with 30G. So then, to me, in my practice, this is not a problem. This is not a problem. I'm using all types of needles without destructuring the foam. If the people that is asking this, if he has interest in this, we can share with him videos that show it very clearly.
Email at the end.
Perfect. Well, thank you. We have another question coming from Italy. If necessary, do you treat from the ankle to the groin, or do you inject from the knee upwards first and maybe do the distal part on a different session? That is to say, do you stage your procedure when it is a long vein, or do you do all of it at the same time?
Yeah, thank you very much. It is a very, very good question, because I started doing the sequential treatment. I started doing first the thigh. I only treated the thigh. I controlled the flow from down with a smart, and I did a puncture in the middle part of the inner part of the thigh, injecting maximum 8 to 9 mLs of foam. And the effect was the occlusion rate around 80%. What I saw is that when I started to combine the injection from the main tributary below the knee, I saw a almost 100% of occlusion rate. And then I swift from the sequential treatment to the total treatment, non-sequential. The main disadvantage to do that is that sometimes there is an overdose of the distal part of the tributaries, and then you have an inflammation. So I think it's a very good question. You have to balance. I think it's good to do it sequential, but now I am doing more in one-stage treatment because people are more happy if they see that just in one session, you have a total occlusion from the groin to the main tributary, also the tributary.
Thank you, Enric. We have another question. Can flushing saline prior to sclerosing change the concentration inside veins?
No. Okay, so let me tell you. When you are using a stable foam, you have to imagine that you are injecting something more or less solid. It's not solid, of course, but even you are first, the effect of saline flushing is to empty the vein of blood. The blood is the enemy of the drug. The blood is the enemy of the sclerosing agent. So then first you empty the vein, you feel and you try to squeeze the vein to reduce the diameter. This is the first thing. So first is empty the vein. Second, reducing the size. And then when you are injecting the foam, if the foam is enough stable, the concentration of the foam is not changing because it's not mixing with the saline. And the effect of the drug against the endothelium is in a few minutes inactivated. So then you don't need to have a foam stable for a long time of period. You need something stable that makes the effect the first minutes. Maybe 2 minutes is enough to have the lesion of the endothelium. I can show you in the meantime if you have more questions, but I can show you other case of cavernoma. This is a okay. This is a recurrent varicose veins, big recurrent varicose veins in a young and tall patient. In this case, if you want to have a good results, I'm using low nitrogen because my estimation was the use of more than 10 to 12 mL of foam. I did an echo-guided access from the cavernoma in the middle part of the thigh. I keep the access.
Pero ves que la punza
Tapes.
pone reflujo y la deja con la jeringa ahí. Con fisio.
Someone from Argentina is commenting. You can talk if you want. Do you want to ask something? So this is a convenient way to do it. Of course, we are wasting a lot of syringes, but it is very easy. You need to compare the cost of this against putting the patient in the operation room using a laser or radiofrequency. Sometimes I'm doing radiofrequency, but mostly my patients are asking for a non-surgical solution. And this is the result of these recurrent varicose veins that you see some scars from previous surgery. This is another case, a patient with recurrent varicose veins. Once again, a cavernoma in the groin with a butterfly 25G. In the middle thigh, I inserted a short catheter. I am using glass syringes because glass syringes are the best for the stability of the foam. I know it's not convenient, but in my practice, I have my own sterilization machine, and this is very, very, very common. Here, this is the spasm test. Once again, I withdraw, red blood is coming to you. So then it means that you need to inject a bit more of foam, or to keep the foam in a stable. Here, this is a spasm test, positive. This is not necessary to inject more foam here. And this is the exact compression example. This is another case.
Thank you, Enric. Could we pause for a second? I think now is a good time to have 2 more questions.
Okay.
So we have another question that is, how often and how many days after the procedure do you need to do blood release, thrombectomy? When you treat GSV or SSV, no side branches, only trunk. So he says this is the last question, I promise, but don't worry, please ask all your questions. That's why we're here.
No. So this is a very good question, because in my experience, only a few patients are needed to be release the thrombus from the main great saphenous vein, because the main great saphenous vein is surrounded by the fascia, and although is a huge great saphenous vein with a very inflammatory reaction, I'm not doing entrapment release, only in tributaries mainly, but not, of course, sometimes it's necessary to do it, and when it's necessary, I do it with the duplex control. With the duplex, with the probe in the longitudinal view, I then make a puncture in the vein, and then I withdraw the thrombus. You can do it after 3 weeks until maybe 2 or 3 months, because when you have a big vein, when you have a big varicose veins, sometimes the thrombus is there for months, and it is not rare that after 3 months, if you have a darkening, you have a hardness part of the skin and a darkening of the skin, then I very obsessive to drain the thrombus, but mostly is in tributaries. In case of GSV or in SSV, I think I've never made this thrombus release entrapment. But it's a very good question.
Thank you, Enric. So another question is, a published study from multiple centers in Italy indicated that veins up to 20 millimeter in diameter were treated. Do you have any restrictions on vein diameter in your practice?
Yes, of course. I am not using foam except is a special case for a special demand from the patient that they don't want to be treated by surgery. But it is not common that I treat with foam patients with 20 millimeters GSV. It's not common because first the occlusion rate is not very good, and in those cases mostly are linked to obese patients. It's common that obese patient has a very wide great saphenous vein. In those patients I would treat or I would propose other strategies to be treated. This is my threshold is around this. In summary, just to remind, for GSV, in case of using air, my bath is around 10 to 12 cc's. If you estimate that it's necessary to inject more in male patients, big varicose veins, I would recommend the use of O2 CO2 if you have the option using VARIXIO device. In SSV, I am very, very cautious about the volume of injection. I would say maximum 6 to 8 cc's per session, independently if it's air or O2 CO2. In anterior saphenous vein, is very variable, the volume and the length of the disease vein, but mostly volume is similar than the GSV. Regarding the concentration, I'm using polidocanol. I'm not using STS, but I know that people that they use STS, the GSV for treating the GSV is around 2 to 3%, the same that polidocanol. In SSV is 2% polidocanol, STS 1 to 2%. And especially, this is important, in anterior saphenous vein, because the major part of the length of the anterior saphenous vein is superficial, is not surrounded by the fascia. I would recommend to go down in concentrations, no using 2%, because it's too much. In my experience with the device, the foam prepared with VARIXIO is more thick and more irritative. So then I would recommend 1% or less, 1 or 0.7%. After the treatment, as I commented before, exciting compression for 3-4 days, and class 2 stocking 2 days all day long, and until the next session during the day, 3 to 4 weeks.
Enric, we have another question now.
Yes.
That works well with after the treatment, is how do you treat hyperpigmentation after treatment?
Okay. If I have a reaction, sometimes after 3 or 4 weeks, if you have a darkening, is because of the inflammation. This is before the pigmentation. A real pigmentation appears after 1 month or 2 months. So then you have the opportunity to be very, very, very cautious, avoiding the pigmentation if you release the thrombus. I am obsessive doing that. All my patients that came to my office after the treatment with the skin a bit hard, or they feel something annoying feeling, or there is a slight dark skin color, I go then to release the thrombus. Once the pigmentation is in the skin, the first thing is try to relax the patient. The expectation of the patient is very important, but in 6 months, the major part of pigmentations disappear. If not, I have a formula with hydroquinone that to whom it could be interesting, we can share with them. This is a formula that my pharmacist prepare. Is a kind of peeling, is a kind of treatment of peeling of the skin. But this is only made after 6 months. Before 6 months, I don't do nothing, only release the thrombus.
Yeah, so we can see that, yes, people wanna that you share it. So yeah, we will share that with you. We'll make
Okay,
sure
no
that we
problem.
are sharing it.
Okay.
We have another question. In time of foam flushing, do you compress deep femoral vein in the groin with probe?
No, and no, it is not necessary. Okay, let me tell you a technical point. I compress the femoral vein just to make easier the spasm of the great saphenous vein. I am not compressing the femoral vein to avoid the theoretical effect of risk of DVT in the femoral vein. This is very important. When I compress, it's because I want that the great saphenous vein could be well filled and spasmed. It has been demonstrated by the experience using other devices as Flebograph, Clarivane, that if you are injecting the drug close to the femoral vein, the risk of DVT is not higher than other techniques. This is because the flow of the deep venous system, and this is because the inactivation. So then so many people are worried about the effect of the foam in the groin or in the femoral vein, but this is unreal and is a non-real fear that is not based in the evidence. The evidence say that if you are doing foam sclerotherapy in the great saphenous vein, when the foam is arriving to the femoral vein, is immediately washed and inactivated. A different story is when you are treating SSV. In case of SSV, there is two things that are different than GSV. First is because it's you're perforating the veins of the calf veins and the popliteal vein is so close than the part of the injection. The spasm of the small saphenous vein is quick, and when you have a quick spasm and then you inject the foam, you have a lot of fresh foam that is in the popliteal vein. And that's because I explained that I try to limit the volume of injection when you are treating the small saphenous vein, much more than in GSV. In small saphenous vein, you have to be very cautious about that. Next.
Yes.
Two.
Yes.
So the limitations for me, the very large veins, GSV, reflux in obese patients. If you have a large GSV patients with a body index high, I think it's better to plan other techniques, or minimum inform the patient that the occlusion rates are poor. So the second main advice is, if you can't offer surveillance, it's better not to do foam sclerotherapy for GSV or SSV, because this is a technique that you can't compare with endothermal approach. The ultra-guided foam sclerotherapy, this is something that you have to explain to the patient. You need at least 3 visits. One session, the first, the second session to see how has been the first, probably to do complementary treatment, and the third session to be sure that the first and the second session have been successful. So then, if you can't, you can offer and guarantee at least 3 sessions, don't do it, because it's bad for the patient, it's bad for the technique. The third thing is standardize the preparation. So the quality of foam is important, and to offer the O2 CO2, I think is quite important for the future. Finally, the lack of training. So people that have to do that, they have to be trained, because it's easy to have some mistakes, and mostly the problem of people that they are not trained is the overdose in volume and overdose in concentration. My final take-home messages. The reality is we can discuss about that, but more and more data is being collected about the relevance of this technique in some cases. The better foam should demonstrate better outcomes. This is something that we are going to demonstrate. Maybe the difference are not very, very huge, but the reality is, if you are using, for safety reasons, physiological gases, this is an unarguable advantage for the patient. This sclerotherapy is increasing. This is normal, and more guidelines are appearing with more recommendations. And of course, if you compare with other techniques, if you are operating patients, if you are taking the patients to the operation room, this is another technique that you need to learn because it's another weapon, it's another thing that you can to offer. So it's a cheap, affordable alternative to other methods. And thank you very much for your attention.
The pictures.
Thank you, Enric. We have some more questions. So there was a question, I'm sorry, some minutes ago, that is, what about accessory vein close to FSJ?
Okay, the accessory. So curiously, when I treat the ASV, it's very, very curious because I'm treating the proximal part of the accessory, the anterior saphenous vein. I am not treating the short part of the GSV. I'm treating the proximal part of the anterior saphenous vein, and then the occlusion is at the level of the connection of the ESV with the GSV. If you have a healthy GSV, if you inject the correct amount of foam in the ASV, when you check the patient after 1 month, you see the GSV patent and the occlusion is at the same level of the connection. Probably because of hemodynamics, matter of flow. This is my personal thought about that.
Thank you. So we have another question. How do you solve the EFIT problem or EFIT problem? I'm not sure how to pronounce it. Do all patients receive VTE prophylaxis?
Sorry. The DVT problems.
Well, the first question was, how do you solve the EFIT problem? I'm sorry, or if it's EFIT.
Oh, okay. Yes. As I mentioned, the reality is when I check my patients, the EHIT or the EFIT phenomena is a limited phenomena. I am not worried about that, and I am only using DVT prophylaxis only in patients with history of DVTs, only in those cases, or maybe if there is a case of older patient with comorbidities, or if they are worried about they ask for, they have fear about that, and then by defensive medicine protocol, I am using anticoagulants for 3 days maximum. But this is not the main fear that I have. I have in my history, I have had 3 DVTs, one related to a lady with history of thrombophilia, and was a treatment of reticular veins, tributaries from small saphenous vein. This is one case. Another case that I had was a DVT after 3-4 sessions of foam sclerotherapy, and was treated by the SSV and GSV, both by the foam. And after the 3rd session, I don't know why, I had a DVT, probably because too much foam in that case. It was a technical error. And the third was other patient that I didn't know exactly what was the reason. But I've treated hundreds of patients, and I made thousands of sessions of sclerotherapy, and my DVT rate is very low. I less than 1%. I don't really remember, but I made the review. I can share with you if you want my data. I'm not worried about that.
Do you want to comment?
Thank you,
Yeah.
Enric. So we have another question, well, actually two more questions. So the first one is, what is your opinion about using of Califer Nano Lactoferrina cream for post-sclerotherapy pigmentations?
I think that I have no experience. So then, because I have no experience, I can't say it's okay or not. Probably all type of creams with a Kellen effect are a good option. I think that what is more important is in the next days after the treatment, the first days, the release the thrombus is the best way to do it. This is the one thing. And the second thing is obvious. In my practice, I am trying to go down as much as possible with the concentrations. In case of GSV, SSV is different, but in case of tributaries, as much as I can go down, I do it to go down with the overinflammation and the overdose. Reticular veins, I treat with 0.5%, 0.3%, I dilute, or no, I am not using 1% for tributaries. In this case, you can see in the screen, in the right, to the right, you see the knee veins. On this part, I would use 0.7%, 0.5%, no more than 0.7%. And the same to the left. In the case of the big veins, big tributaries, you see in the number 8 a slightly pigmentation, but this is the rest of the occlusion after a very obsessive drainage of the thrombus entrapment.
Thank you, Enric. So we actually have some more questions coming up. So first of all, it's most famous doctors inject the GSV top to bottom with at least 2 puncture sites, mostly 3. Do you have tips and suggestions when to use one technique or the other?
No, as I commented before, I started with a one-axis strategy. I started doing only one axis in the middle thigh, limiting the flow coming from down, putting a smart in the knee. And what I saw was occlusion rate, it was not excellent. The occlusion rate was around 90%. And then I switched to the English method, that the English method consists in put different axes along all the length of the great saphenous vein and tributaries, put the leg up, and then inject from down to up, from the distal part of the leg to the upper part. And in this progressive injection, there is a very effective field of the vein with the foam. In this case, what I would say is for the English method, I would change the concentration, and I don't like the idea to treat with the same concentration the GSV in the thigh than the tributary in the leg. So then I would change from 0.5% in the leg, in the tributary, and then change to the 2% in the thigh. Anyway, this practical point, what happened is sometimes you tend to be overdosing the distal part of the leg with higher concentrations. The result of this is the inflammation of the tributary, and patient has to know it. patient has to know. You have to notice, you have to inform and be aware of this.
Thank you, Enric. So yeah, we have another comment and question. So he says, thank you for presentation and sharing your experience. I ask this as a vascular surgeon who is hesitant to perform foam sclerotherapy on GSV. So how long do you wait for results after performing the GSV procedure? I understand you do follow-up imaging, but what is the maximum time frame to consider foam sclerotherapy as success? Is endothelial damage within the GSV detected by ultrasound at 1 month considered a success, or should another session be performed?
Okay. This is a very, very, very good question. Because to me, the success of the treatment of any type of varicose veins, especially for truncal veins, is to have or an occlusion rate of 100% and disappearing the vein after 1 year, or having a non-refluxing vein after 1 year, or not having a recurrent varicose veins after 1 year. That I consider it more or less a success, but I don't close as is done, is finished the case, because my recommendation is I don't want to equate the endothermal or the stripping to the foam. I think that you can treat almost 70% of your patients with foam sclerotherapy, even great saphenous veins, because the occlusion rate at 1 month can be 100%. But in reality, 100%, it is not a realistic data that you can guarantee. I believe a good result in a long run is 70% in 5 years, or 60% of occlusion in 5 years. The rest of the patients that they haven't had an occlusion of the vein, mostly they don't have big varicose veins. Maybe they suffer from one arising vein, and then you can re-inject. So then I don't like to equate exactly the endothermal or the stripping to the foam. They are different costs and different. I don't know. It's a different approach. But of course, I know this is a very controversial, and maybe we should compare in a different way. Quality of life is probably the best way to compare, not the occlusion rates.
Quizás yo comentaría los casos y las concentraciones que trigger.
So I don't know if we have enough time, but this is a
Yeah,
case.
well, there's definitely one last question. I'm sorry, Enric. So far, there's one more, which is any record for reoccurrence after 2 or 3 years post-sclero treatment? Is there any record of it?
Let me check.
Yes.
Any record? Any record? Yes. As I mentioned, so the varicose veins is a chronic disease. To say this is not recurrences is to lie. Of course, there are recurrences. I have recurrences, but the number of recurrences that I have when I treat a great saphenous vein is less than 20%, 25%. In that cases, after 1, 2, or 3 years, when I have a patient with the recurrent varicose veins that can be seen or can be feeling, it's very easy to retreat. And then I retreat, and that's it. I I make another puncture in a 15 minutes procedure, and that's it. That's the main advantage of this approach instead or versus the surgical approach. But of course, there is recurrences, and there are more recurrences than in endothermal, but duplex, considering the duplex, but considering the clinical recurrences, this is something more arguable. Do you
And
increase-
Enric, another question
Yes,
is,
yes.
do you increase the
Yes.
concentration when you
Yes.
treat those early recurrences?
Yes, for sure. I keep the 3% polydocanol just for recurrences or for malformations. The 3% polydocanol is the concentration that I am using when I have a GSV with a clear or early recurrence, or if I have a patient with unexpected recurrences, 3%, of course. I'm or increasing the concentration or changing to STS. As I commented before, I had no experience, great experience with STS, but in cases of recurrences, I could change to STS. Upper ligation.
New questions just came in. So any advice for upper ligation in combination with sclerosession?
I would say it's an option. It's an option. You can, of course, if you have an upper ligation and combined with foam, it's okay. But logically, if you are talking about upper ligation, you take the patient to the operation room. So then I'm not sure if I put the patient to the operation room and I need to make an incision in the groin, I am not sure if I would change the treatment for an endothermal, because not necessary to make a ligation. If you are combining ligation with film, you are looking for occlusion of the GSV saphenofemoral junction, and you want to combine the occlusion of the vein. Otherwise, if you are treating the patient with a Chiba strategy, it's totally different, because of course you can make a ligation of a saphenofemoral junction and then apply foam in tributaries, not in the GSV. In that case, I would say, okay, it's a good strategy. If you want to keep the great saphenous vein patent, and then you want only to tie the GSV in the saphenofemoral junction and avoiding the phlebectomies of the tributaries.
Thank you. Well, thank you, Enric. That was very interesting.
Okay.
Yeah, so far I think we have no further questions. Thank you for all for the participation. It was a very interesting and very interactive session. Lots of questions, lots of comments and thoughts. So thank you for that. I hope you enjoyed it.
Okay.
¿Puedo stop?
Yeah.
Yeah. So one more last thing. So we are planning already our next webinar, which will be about in 2 to 3 months. So we will be announcing it very soon. So please stay tuned. And one last thing before we close this session, because we would like to ask for your input. In case you would like to know more about some specific topic, some ideas for next webinars, what you want to hear from us. So we would love to hear some of your ideas and thoughts, what you would like to cover. So your feedback is very helpful for us. So if you just want to comment something in the chats that you would like to know more about, or you can also send it to us later on, feel free.
Okay, so thank you, Alexandra. I think it's very interesting to know And not only the thoughts, but what are your worries about? What do you want to know more in detail about foam sclerotherapy, new indications, how to prepare the foam? I'm surprised about the fact that people are still asking about the stability or the structure of the foam passing through very small needles. And I have a lot of videos that can show you that if you have a good foam, you have a good foam also passing through 30G needles. Anyway, so thank you again. It's very late. I hope it has been useful, and be in touch and ask for any information if you need. Bye-bye.
Bye.
Thank you very much. Bye, everyone.